So we start the session and I invite Dr. Ashok Sharma, the first speaker for his talk.
Respected member on the dais and friends, I would speak on deep anterior lamellar keratoplasty long-term results. Authors have no financial interest. Corneal perforations need urgent management. Corneal perforations less than 3 millimeters are managed with sinoacrylate tissue adhesive. More than 3 millimeter perforations require tissue scaffold to apply sinoacrylate tissue adhesive. Two scaffolds have been used, scleral patch or Tenen patch. More than 3 millimeter perforations are mostly treated with therapeutic penetrating keratoplasty. Therapeutic DALK has advantage over penetrating keratoplasty, but there are not many studies on this area. This is a retrospective interventional case series. IRB approval and study has been done retrospectively. Comprehensive ophthalmic examination, microbiological workup and autoimmune disease workup was done. These are the consecutive patients of and comprised of 41 patients. Only patients who had to be converted to PKP intraoperatively, they were excluded. There were three surgical techniques which were used. Ab externo manual dissection, layer by layer, was used for most of the corneal perforations. Combined ab externo and ab interno dissection, as shown in this diagram, was in this figure was done. Partial trephination, and after partial trephination, the superficial corneal stroma was removed. On desmatoceles or impending corneal perforations, the deeper Descemet's membrane and deeper stroma was separated using a blunt-tipped spatula. Bearing of the Descemet's membrane was done, and then dark patch donor graft was applied. In some of the patients where we had cricentric Murren's ulceration with perforation, we used no dissection of the host tissue, but customized lenticular preparation was done using two turfines. Making it a geometrical shape, the tissue was required. We had almost 88% success in achieving in eliminating the disease. And these are some of the cases. Murren's ulcer patient with perforation, he came in COVID-19 era, and he was done DALK. And he had good visual acuity 6.9. Neurotrophic corneal ulcer, then post-bacterial corneal perforation, all treated with DALK patches. Now this is one patient who had severe dry eye along with impending perforation. Once he was treated for dry eye, he developed impending corneal perforation. We had choice of tissue adhesive plus DALK, but due to COVID-19, we went for DALK so that no more visits were required. Having good visual acuity, so he was ambulatory. Another patient who had herpes simplex keratitis and was operated with DALK. Some of these patients who were treated for post-fungal corneal perforations, they had recurrences. And same was true for herpes. Secondary glaucoma, cataract and retinal detachment were some of the other complications. I would like to say that minimal invasive DALK is minimal invasive and faster healing, spares the angle, and there is a lower incidence of glaucoma. Combined ab externo and ab interno technique in addition to tectonic provides good visual outcome in some of the cases. Customized donor lenticule preparation with two turfines is easier than manual technique because it is very difficult to cut the full thickness donor cornea to the desired shape. Another advantage is that the glycerine preserved donor tissue can be utilized. Therapeutic DALK can be useful during pandemic conditions like COVID-19. I would like to conclude by saying that therapeutic DALK is a safe alternative to PKP in selected cases. In addition to tectonic support, elimination of the disease may improve the visual acuity. And therapeutic DALK, if we have to perform, we should be cautious in selecting cases of fungal and herpes simplex keratitis as there is high risk of recurrence following therapeutic DALK. Thank you very much for patient hearing.
Excellent presentation, sir. Ma'am, please.
Please go ahead. I just wanted to know that this was only for peripheral ulcers or this is for the central perforations also?
I have done for central perforation also and peripheral perforation.
So how do you get the endothelium in that area, in that perforation area? Because if you said that the perforation is larger than 3 millimeter, and then that area will remain devoid of perforation.
Yes, madam. Then the trephination, partial trephination will be done.
And the endothelial part, how the endothelium is arrived at that place?
How the
Because
endothelium?
unless endothelium will not grow and cover that area, so that area will remain without endothelium.
No, madam. What has happened is that
Was
if the perforation is small, and if we apply a lamellar patch over it, then the endothelial cells, they enlarge and they cross over the host gum junction and they cover that area. I have published one case report in which there was a peripheral corneal perforation, full thickness, and we did glycerin preserved graft, which was stored for more than 2 months in the glycerin.
It's good
and
for peripheral
that
perforation.
and
That's
that
what I
patch
was
also,
asking
and
you.
that patch also cleared. So endothelium slides over and clears.
Good, thank you.
Would you, in case of fungal, like you said, it is used in selective cases, right? So would you recommend doing this in fungal corneal ulcer with perforation?
No.
Because you have included some cases. So,
No.
So suppose if you see today one case with perforation and fungal corneal ulcer, proven fungal maybe, and what would be your first procedure of choice in such cases?
Well, you see, if
Because I think we have to be very cautious in recommending such procedures in fungal ulcers at least.
that's what. You see, even for like non-dissolving fungal keratitis, with all the antifungals, the deep anterior lamellar keratoplasty has been tried. And in that case also, there is a high risk of recurrences.
Yes. And
So we
recurrence
thought,
is again very difficult to
and
treat in that.
in these patients where the like already because we are treating with the fungus or bacterial ulcer, the collagenolisis occurs and then the perforation occurs.
Yeah.
So most of the time the infection is relatively under control, but still in fungal cases recurrences occurred. So that
this
is the
not
problem.
advisable in fungal.
I
as of
would
now.
not advise.
As of now.
I would advise
It just
penetrating.
retrospectively you have included because you have
My choice would be penetrating keratoplasty, therapeutic penetrating keratoplasty for fungal.
right.